Chitra ma'am is joined. Vinayak sir has
I
joined.
have not.
Shalini
Okay.
Masim and Geeta madam has joined or not?
Ma'am, let me check one.
Good evening,
Geeta ma'am.
MKC
Then
sir.
we will start.
Good afternoon, sir.
Yes, good afternoon.
Good afternoon, sir. Namaskar.
Good afternoon, Priti, Dr. MKC sir.
Kavita ma'am has joined.
Yeah.
Amar Singh sir has joined.
ऑलरेडी सर एका आश्रमामध्ये ऑलरेडी काम करत होते सर्व्हिस पेडिशन टू सम years right त्यांनी काहीतरी
Shall we start, ma'am?
Yes, you start, Shilpa.
म्हणजे अटॅचमेंट आणि
So-
त्यांची हेल्थ अतिशय व्यवस्थित आहे
Members and distinguished guests, I welcome you all. The fifth session of our
काम करतो तो व्हायचं
In office illa. Link of
May I request everyone to be mute? So it's with great pleasure and
Shilpa, unmute.
You're not audible.
Shilpa.
it's coming out. Sorry. So we welcome you all to the e-webinar on adolescent counseling in office practice basics and beyond, organized by Chhattisgarh AHA, very well designed, advised and proposed by Dr. MKC Nair sir, Dr. Preeti Galgal and Dr. Kavita Menghani ma'am, with immense support and guidance of Central IAP and Central AHA. Before we delve into today's engaging session, I would like to extend a warm and cordial welcome to our distinguished guests of honor with us for today's session. Please welcome Padma Shri Dr. A.T. Dapke, sir, a beacon in the medical community whose contributions have been invaluable and far-reaching. And we are also graced by the presence of Dr. Sneha Gadkar, ma'am, 2024. We feel privileged to have both of you with us as guest of honor for today's session. With equal pleasure, I would like to welcome and thank the office bearer of Central IAP 2024, the office bearers of Central AHA 2024 in the guidance of Dr. G.V. Basavaraja sir and Dr. Geeta Patil ma'am, Honorable Dr. Ashok sir, EB member Central IAP 2024, and the CGIAP office bearers 2024 in the guidance of Dr. Kiran Makija sir. I also welcome Dr. Shalini Masin ma'am, Dr. Neelam Mohan ma'am, Dr. Ashok Sundarani sir, Dr. Amar Singh Thakur sir, Dr. Sangeeta Joshi ma'am, Dr. Madhushri Deshpande ma'am, Dr. Hima Bindu ma'am, and Dr. Amok Shahane, and all other esteemed participants who have joined us today for this enthusiastic session. We extend a gracious welcome to our honored chairpersons for today's session, Dr. Raghavendra Singh sir, well-versed and proficient senior consultant pediatrician from Raipur, and Dr. Akash Lalwani, an astute and acclaimed consultant neonatologist and pediatrician from Raipur. We are to have with us two eminent speakers who bring a wealth of experience and profound knowledge in the field of adolescent health and well-being. Dr. Chitra Dinkar madam, an esteemed adolescent health specialist. She will guide us through case-based counseling in romantic relationship. And Dr. Vinayak Koperde, sir, a respected psychiatrist who will enlighten us on dialectical behavior therapy. Now, it is my distinct honor to invite our esteemed guest of honor, Padma Shri, Dr. A.T. Dapke, sir, to offer his insights with us. He is the one who unparalleledly contributes to the field of medicine, and his unwaveringly commitment to advancing healthcare have been an inspiration to many. So may I request Dapke, sir, to say few words and address the gathering.
Good afternoon, all of you. especially the speakers, the chairpersons, the special guests, and of course the organizers who are taking. I can tell you, I have not missed single minute of these adolescent seminars. I think they are very, very pertinent to all of us. Few points I thought I would discuss with you. Ours is a country with a very, very wide spectrum of population. The variation includes some are in remote tribal areas, some are in areas which are not approachable. Third, some are in areas which are approachable, but they are financially poor. And fourth, they are very rich persons who have no time for their children. Now, in this situation, the effects of all this child rearing are seen when they reach the pre-adolescent and adolescent age. And in early and middle adolescent age, they find difficulties which have long-lasting effects. So I thought if we want to summarize till now all sessions, most important is parents have to be motivated so that since there are already more than 700 papers on role of meditation, meditation therapy and all that, this therapy, India is one country where it can be, if pursued nicely, it will be most cheapest form of treatment and most effective. These children will be able to fight, will be able to run their life and see their progress if they have this sense of little, what you call, stability and how to maintain stability. So Professor Nair has very rightly said that this therapy is very useful in so many conditions which you all know. I would request that a small sentence of maybe one paragraph should be a message to the public. Those who are very rich, they appoint some Pandit ji for their children, puja uja kar lena, hamare ko time nahi hai. Now, this is a situation, probably it's all right for the individual, they think that Bhagwan ko bypass ho jayega apna message through this other person. But what is, as soon as child starts walking, maybe second year onward, at least 10 to 20 minutes should be spent by parents with child to a place of meditation, if not daily, at least 2 times a day, which should be done very regularly. This will add to the child's thinking, his way of fighting and organizing his career. And I thought if this is taken very seriously, our populations, which are very wide range, they will be benefited, their children will be benefited, and this will be a very useful intervention causing very minimal cost. Because if you see, there are thousands and thousands of people going miles and miles carrying pure water and offering it to the God. Now, this process, after this process is over, they feel अब अपने को भगवान ने कर लिया है सब, अब now we will see next year. Now, so this approach has to be changed to regular intervention, and I am sure with this intervention, probably so many adolescent problems of depression, anxiety, including adolescent addiction, can be postponed, can be managed, and even to some extent prevented also. Once again, I feel the experts which are being guiding us so long, we won't analyze the situation of our very tribal children also. What is their adolescent problem? What are their progress? How they happen? And in this, I will give one example, which in a adolescent IQ testing expert, they showed an aeroplane to a boy. And the boy said, this aeroplane there is something wrong. There is no fan in this. So, and the examiner gave this child full marks. Same question was asked to another boy, and when he saw this aeroplane, he said, no, this is all right. There is nothing wrong in that. Now this examiner who gave full marks to the previous child, he said, how you can say that? Sir, there is no fan in jet planes. So this is a jet plane, so you don't read a fan. So this is now here, the boy who was in cities could understand the jet planes. The boys who were in the very remote area may not be. So our evaluation should be expanded and more seriously done. And I think it should be a part of our adolescent societies or committees meeting, so that the huge country like us, we have a very, very big data and usefulness is. Once again, I am jealous of all the experts who are so intelligent. मैं उनसे जलता इसलिए हूँ कि मैं उनकी एज में था तो मैं बहुत गधा था. अगर मेरे को भगवान उनकी इतनी दिमाग दे देता तो मैं काफी होशियार हो सकता था. Once again, thank you all. Thank you. I have to attend my very close relatives meeting. He died yesterday. So that's why I have to take your permission for leaving. Once again, thanks and regards to all of you. Thank you.
Thank you, sir. Thank
Thank
you.
you, Dakya sir. Thank you.
sir.
Thank you, sir, for taking off time from your busy schedule and for these thought-provoking ideas which you have given to us. Thanks a lot. Now it's a great pleasure to invite our respected guest of honor, Dr. Sneha G. Gatkar, ma'am, to share her thoughts with us.
Thank you. I am really honored that you have given me such a big honor today to be a guest of honor. And really, these webinars are making us more wiser and wiser day by day in order to understand the adolescents and their problem. Today's topic is very good. And what I wanted to say, that being a nuclear families and both parents working, adolescent care requires lot of precautions. And
Very
because they find affection, they want to find affection which they don't get at home these days, because parents are working, grandparents are not there, and rest of the time is spent in media by whole the family. So somewhere that cuddling, affection and love is missing, which they try to find out in the adolescent age group as soon as they grow. And this age is very tender, and they should understand, and we should ask them to understand that this relationship never turns. Only 5% relationships are successful at this age, and they should be discouraged. And if they get a strong family background, or what we call as a strong sanskar, then no one can deviate in the world from your motive and your target in the life. So basic foundation lies at home, and sanskar should be there in order to have a complete normal child with the all direction, like spiritual health, mental health, sexual health and social health. Everything is being done at home if the foundations are good. With that, I will give thank you to all. Thank you. Looking forward for a good lecture now.
Thank you, ma'am. Thank you. Thank you.
Thank you, ma'am, and thanks for your words of wisdom. Our session today will be chaired by two highly respected consultant pediatricians. It's a privilege to expertise in pediatric care is widely acknowledged and deeply respected. He is past of CGAHA, as well as he is an important pillar in the IAP of Chhattisgarh. He is the most humble doctor I have met in my life, that I can say, because he is my senior. And I would like to invite Sir to address the gathering and introduce our first speaker, Dr. Chitra ma'am.
Thanks, Dr. Shilpa, and a very good afternoon to everyone, my dear colleagues, my fellow IPNs, my seniors, everyone. I wish a very warm afternoon and very good afternoon. Dear, I would like to thank the CGAHA, especially Dr. Kavita, Dr. Shilpa, who have been doing a wonderful job since they have started their tenure, and all the past presidents and the team who have done a marvelous job since the inception of CGAHA in a very short span of time. As far as today's topic is concerned, as ma'am has already said, that it is a very tender age, and adolescent being such a vulnerable age, that hormonal changes, physical changes, a whole lot of peer pressure and social media, TV, media and everything, they are very natural to fall into many kinds of relationships, being friendships, other relationships, and also the romantic relationships. To guide us more on the relationships, especially the romantic relationships, on a case-based approach and case-based counseling, we have amongst us a very respected, a renowned member of our society, of Adolescent Society, Dr. Chitra Dinkar ma'am, who is Professor and Head, Department of Pediatrics. She is also Head, Teen Services and Pediatric Infectious Diseases at St. Martha's Hospital, Bangalore. She is also former Professor and Head, St. John's Medical College Hospital and St. John's National Academy of Health Sciences, Bangalore. Her areas of interest and experience have been in infectious diseases, especially in TB and HIV, in also adolescent medicines for more than 20 years, and community pediatrics. She has over 45 national and international scientific publications to her name, and she has been awarded at various state and national conferences for her best research papers and case presentations. So on behalf of everyone, I would like to welcome Dr. Chitra Dinkar ma'am to start her talk. Now over to you, ma'am.
Thank you, sir. I'll go straight to my screen's share. Yeah, so basically, my talk will be a case-based approach to counseling in the context of romantic relationships. The objectives of this session will be to empower pediatricians like us in sexuality-related counseling of not only adolescents, but both their parents, guardians, and stakeholders.
నేను ఇవ్వలేదు కదా అది అప్పుడప్పుడు వెళ్ళి చూడు అక్కడ
To achieve the objective, I would like to look at some aspects of basic normal sexuality development during adolescence and share 3 of my own cases, which I had occasion to manage in the area of sexuality and romance. And what I will be trying to do is to focus on some practical counseling tips, which would be useful, hopefully, and also emphasize that there's a very individualized management in these scenarios with no one way of managing all. And I hope the house takes away what would be useful for each one. Going to normative development, when you look at the broad categories of early, middle, and late adolescence, we all know that the first part, roughly 10 to 13 years, is focused more on body changes, pubertal development, a lot of focus on the changes in limb, genital, breast development, and there is a lot of self-conscious focus internalized at this stage with concerns related to body image primarily. However, during mid-adolescence, 14 to 17 roughly, you would have a little more comfort with body changes. And now, with same-sex groups, there would be some exploration of what they would look at as a market value for themselves as partners for future. And there would be definitely a heightened conflict with parents, teachers, and also a tendency for sexual experimentation. So what I would like to highlight here is these are normative developments, basically like other phases of development during adolescence, which we accept, bits for autonomy, your conflict resolution, how they get better at their thinking skills and their cognitive abilities. This too is in transition, and we need to accept that that is the truth of the matter. And late adolescence is when they have been able to put their sexuality in context to other preferences and priorities maybe, and are a little more firm with what they believe is their own sexual identity, including some kind of a hint or a confidence in their own sexual orientations. They are here able to look at long-term rather than immediate gratification. So when you look at sexual identity development, like I mentioned, in the adolescence age group that we are talking about, it is not final. And they are in the process of understanding who he or she is as a sexual being. And there is an acceleration of sexual exploration, both with self and others. What happens as challenges is what specific feelings and behaviors may affect one person, one adolescent, say, in a particular context, and whether it's developmentally appropriate, whether it is accepted by family, whether societal values conform to what they're doing, what are the legal implications, and what are the knowledge gaps that we have as doctors, caregivers have as parents and stakeholders in the adolescence development, and the adolescents themselves. With this, I'd like to share with you Abhishek, who was 15 years when he presented. He had just got into his 10th grade, and he had headaches going on for the past 3 months, severe enough to affect his daily school attendance. And he had, in fact, skipped 2 to 3 days in a week over the past couple of weeks because of the headaches. The headache didn't conform to migraine or any space-occupying lesion or any refractive error. So this was a kind of a tension headache for us, and we are familiar with how to sort out the differentials for a headache. And his parents had now come with a big bundle of investigations, a lot of records from past doctor visits, including a CT, MRI, and eye checkup, labs, and everything was, of course, not pointing to any etiology. So you proceed as a pediatrician to a health assessment, I'm sure, and I did too. And what we would like to explore, and this is, of course, the psychosocial components of this adolescence state, and look at where we can find both the strengths and the difficulties in areas related to home, education, eating, activity, depression, as we know, drugs, then your self-harm, sexuality, and safety. So S is just one S, but in the context in which we are discussing this case, I will focus more on the sexuality aspects. So the home situations was briefly that he had a sister, younger, 10-year-old, doing well, nuclear family. Both parents were working, but they did find time for their child. And he had been in conflict with his parents over excessive media use, sitting up late into the night, claiming that it was his 10th and he needed to use his phone for study purposes. And he would have late wake-ups, miss school, complain about headache, be irritable with them when they confronted him about it, and was not willing to change his ways. So in that sense, that was the rough background of something to do with health. He was a good student, 80% to 60% is what he had come down in the previous exam. And primarily, his parents didn't know what was going on. And they had brought him here for a solving of his headache, which had become very discomforting and had become dysfunctional. And of course, we spell out confidentiality at every stage, but particularly for a sexuality history, you need to re-emphasize confidentiality, say that what we are sharing is not going to be shared with your parents, and then move forward. So after a reasonable rapport, this is what maybe you could use, a practical sample question. As mentioned earlier, I'm going to try to get your headache sorted, Abhishek. And what you share with me is only between us, and I'm not going to be discussing with your parents without your permission. And I'm clarifying what I'm going to do. I would like to understand all aspects of your health, including about friends, and see if there's anything bothering you. So that's what I'm euphemizing for stress and relationships. And I'd also say some boys and girls at your age may have a close emotional or romantic relationship with a special friend. So here I'm not saying most boys and girls or all boys and girls may have a close relationship, may have a boyfriend, girlfriend. I'm trying to be gender neutral if you notice here. So I would not normalize it, but not, give ideas to them and say most people have, and if you don't have, you have a problem, or the other way around. So some boys and girls at your age may have a close emotional or romantic relationship with a special friend. Do you have a special friend that you are emotionally close to? I'm not straight away asking about a romantic relationship, right? And then you wait and listen to what he has to say. And do you love anyone? Then you wait and listen. And have you had sex with anyone? Is based on what he says. So what did he say when I waited and listened? Yes, he does have a relationship. And he loves her very much. And they are very steady. And he has no problems with the relationships. Okay. And no, he has not had any physical intimacy. So this is what he had to share. So when you look at what you are going to do in a scenario like this, where you have got a share from an adolescent talking about a relationship quite normatively and saying yes. So you're going to be looking at your role as focusing on health, both the physical and the mental health aspects, hygiene, both your genital as well as bodily hygiene, and safety, looking at whether the practices, behaviors of the adolescent will keep them safe for now and for the future. So when you look at the physical and mental aspects, you would be in general focusing on issues related to body image, all your orientation, identity, if there is any issue there. What about your ability to solve problems, your empowered state, whether you are a little mature or able to have an insight into your own difficulties to find solutions for it, or do you have a person in the home who can help you with it? What would be your actions based on your values? And do you even know about what is responsible sexual behavior? So here, in the context of romantic and sexual relationships, we would definitely be covering menstrual genital hygiene, because we all know the role of UTIs, STIs, menstrual hygiene in predisposing to infections, which are also transmissible. And when we look at safety, we are predominantly looking at infections. STIs basically are infections which are asymptomatic. STDs are infections that cause symptoms and disease. And they are not only limited to HIV. HIV is one of the STDs that are about 30 plus, viral, bacterial, parasitic, etc. So you would also look at vaccinations for hepatitis B if they've not got it, catch up, and HPV. And you would be talking about prevention of pregnancy if they are sexually active. And you have to have an index of suspicion of any form of abuse in the context of a relationship. So the abuse could be physical, emotional, sexual, in the context of a romantic relationship. And you may have to have that in mind and maybe even clarify for the adolescents themselves if it is a situation they are in. So with these broad focuses on health, hygiene, and safety, more about Abhishek. So he said he's in a relationship with a classmate, that is his own 10th grade, for the past 1 year. According to him, she was absolutely okay with it, and they have been calling themselves girlfriend, boyfriend for the past 6 months. And he has long chats with her in the night using his phone, and he was not happy to reveal the details of any, because I also didn't probe him. I just gave him an opening to share whatever he wanted to share about the level of his relationship. Obviously, he was sleep deprived, and there was a lot of stress from the parents for the media use. They were not sure why he was spending so long, and the fact that he had dropped grades and was having this headache. And when he was teased about, what do you think about the relationship itself? Do you think you would like to change anything about this? He was very clear that he was not interested, because this was what he was very happy with, and he didn't want to change, or he didn't see the need to change. And of course, he had a lot of knowledge gaps when we explored a little further into some important preventive health education. So this could be a scenario, and what we as counselors could look at is getting educated ourselves to look at accepting this as normative for him. We said he's 15, he's in middle adolescence. We know he will be exploring. Developmentally appropriate, yes, at least for physicians, if not parents. Confidentiality, I reiterated it when I had a conversation so that he came out with this, because he knew I was not going to share it with his parents at this stage. Otherwise, invariably, he would have held back even something as normative as an exploratory relationship. And I normalize the sexuality questioning, like I already explained. And basically now what I'm going to say is I'm going to be talking to you about your health. I'm your doctor. I'm concerned about your health. So I'll be covering areas of health, both physical, mental, hygiene, and your safety. And maybe your partner's safety because you care for her too. And in that context, I'm going to be saying what I'm going to offer. I'm going to say that you can share or not share what you feel comfortable with. There is no compulsion, but I'm here to help you. And I'm going to be talking of not just physical health of headache and genital hygiene as well as any symptoms there, but I would be looking also at what he thinks about it, how his feelings are about this whole relationship, and what about his handling of his parents, her parents, etc. And the behaviors he's engaged in terms of whether it's safe or can be made safer. So identify what help is required of you. So through his share, I get to know that he doesn't want to share more about his the details of his sexual intimacy. And with what he has shared, I think I can go forward to help him out at that step. And what I need to do in any session where I'm addressing this is to set specific goals and look at empowering him to have insight and solve his own problems. Because once I give him an example, he'll be able to translate this to more and more situations that are going to be cropping up day to day. And at any point, if I find it's beyond me, please feel free to refer. So sexuality counseling, if I might note, is directed to developing a positive sexuality, which implies a capacity for caring, supportive, non-coercive, mutually pleasurable, and safe sexual relationship. So what Abhishek is doing is practice for this, hopefully. And here basically is positive relationship, but maybe there is an implication for his other goals where it is conflicting. The WHO definition for sexual health is a state of physical, mental, emotional, and social well-being in relation to sexuality, not merely an absence of an STI, STD, or any dysfunction. So in that sense, for him, age-appropriate, his sexual health is on track, but it is causing some dysfunction. So if I may just share here, children learn what they live. This is one of my favorite posters in the place of my work too. If a child lives with ridicule, he learns to be shy. If a child lives with shame, he learns to feel guilty. Okay. And if he lives with praise, he learns to appreciate and so on. So here in the context of sexuality, there is a huge stigma and ridicule. And this gets very, very augmented in our current scenario culturally. And if he lives with shame, obviously he's going to be not looking at a very positive first experience in his sexual roadmap. So if he lives with acceptance and friendship, he learns to find love in the world. So what we need to do is sort out the relationship in the context of his other goals and look at how developmentally we can get him to get empowered to manage his situation. So in very brief, without going into very elaborate definitions, sexuality is the sum totals of one's thoughts, beliefs, feelings, and behavior towards another person. And sex itself is just a physical act of intercourse, and everyone seems so focused on not, getting there that they miss out on normal sexuality development in adolescence. So I think what we need to focus is on the normative adolescent sexuality development and support. So counselor skills, of course, you have to define your role and capability. I already mentioned how you would tell the adolescent why you're talking about this. And you have to just listen 80% and only talk 20%. And you need to understand what the adolescent thinks and feels about this. So Abhishek was very positive about his relationship. He was all praise for his girlfriend. And he said she's a very good student too. And she helps him out in focusing better and studying, etc. So active listening literally means that, okay, I understand. Yes, good. You must be feeling good that, you have a good girlfriend. Open-ended questions, because unless I know what he's thinking and feeling and what he wants to do, I have no answers for him or no way to help him out. And I need to be, even my body language should be of something that is not judgmental or very, giving away any kind of a moralizing. And it's very, very important to be aware of what you yourself believe, because you need to put your professional self ahead of your parent self when you are in an interactive discussion on sexuality with an adolescent client. So some of the things that we can look at is also accurate information goals, accurate information, your health education, looking at all your relationships, very important life skills on how particular scenarios happen, a problem, and how he can solve it with his own inputs and in his own context, with his parents' support if needed. And definitely you need to look at him questioning his own morals and what he feels about an activity which involves intimacy or otherwise, and how he sees his role as responsible in this relationship. And definitely, with or without his admitting it, you may need to definitely touch on aspects related to contraception and STD prevention, or offer him resources to access it, because then he is not going to come out and say, yes, I'm in a relationship and I may actually end up with a problem. So abuse, many adolescents or teenagers in love don't realize they're actually having an abusive relationship because they are so blind to the whole concept. So only if it is physical and maybe if it is sexual, they may denote it as abuse, but emotional abuse many times gets a little hazy and they're not sure whether their partner is really abusive. So some goals for Abhishek, looking at health, hygiene, and safety. I'd like to repeat this again and again so that we know where we are when we are talking about these aspects. So you're looking at his physical, his problem is headache. So we need to, link the headache, the stress related to the time it is taking, the media, the time he's spending on the phone with his girlfriend, interfering with his studies and his performance and things like that. So his physical, what he's thinking and feeling. There's no way he wants to break the relationship. So you can explore whether he wants to modify something, and behavior, depending on what he shared. Maybe we can have some kind of a talk about privacy, boundaries, and limits. So defining his partner's goals, he said, this is long-term. And we are very happy. We've seen so many childhood romances and we are looking at long-term. Though he may not be in a position to judge that right away. Time management is something we definitely spoke about, and he had complete acceptance of the fact that he needed to do something about the media use. So privacy, boundaries, limits has to be discussed with your partners, what you can share, because what is okay, can she tell her mother about it, her parents about it? What do you feel if your friends know about this or her friends know about it? So what are the boundaries you all have kept for yourselves? This far and no further. Maybe minimal, hand holding, kissing, maybe, I don't know. And then definitely not, sexual intercourse, limits. So these things are important to discuss, and you need to be mature enough if you're in a relationship to be able to talk to your partner about it. So many of them are confused. Some may not be able to assess whether they're being abused, but just saying consensual doesn't make it. So you need to clarify based on what they've shared for them, whether there is some component of all of this. And handling his family's values, because his parents are very strict. They want him to focus on studies. He doesn't even know what they will do if he shares. So there's no question of me sharing the information with his family, but he has to handle their demands for focusing on the right things. And I think he himself has got this insight after the counseling. And knowledge gaps related to safety is what I would like to cover. So if I may just discuss, just explaining to Abhishek about infatuation common in teenagers versus love, which requires more maturity, where it is more trusting, mutually enriching. You're looking more about the partner, not about your selfish needs, and how you are more giving in a love relationship versus a infatuation relationship where you're more demanding and jealous. So, to give some insight on where he is and where she is. And also questioning what do you think is the right time to get into a physical relationship can open up some thoughts from him about what he says. So he says he's not sure. So basically you need to be, emotionally also competent. You are not able to function even as a 10th grader. So do you think you're emotionally ready? Actually, no, he knows that himself. Financially dependent still. So understanding yourself and being emotionally able to handle itself is not this. So when you are not yourself, a little comfortable, you may have more problem handling the emotional storm of a relationship is what he could get. And of course, you need to be caring, love, and concern. When you're having your headache, your pain, you think you'll be able to care and love for another person. Very difficult, right? So I guess better you get it yourself sorted out, and then you can move forward. So integrity is honesty, whether you're being watched or not watched, and responsibility is to take responsibility for consequences. Now you are in a relationship. What responsibility are you able to take? If our parents come to know, if your parents come to know, what are you going to do? So these are the discussions that you could have. And definitely, like I mentioned, many adolescents will not share that they're sexually active, and many do not know. Sex before marriage is a risk factor because you may end up not having a steady, long partner, and you may have multiple partners, and therefore risks of all the partners get added to your risk for STIs, STDs, including HIV. Definitely, men having sex with men or same-sex homosexuality is at risk because you have trauma there and you have anal infections also adding to the problem. Sex with commercial sex workers because, again, of multiple partners and their own health conditions, not using a barrier method, partner with risk factors, ex-partners with risk factors, all those get added to you. And definitely, if you have an infection that is not treated, or if you use drugs, you're going to be taking decisions which are maybe not very safe in the long term. So basically, safer sexual practices, we continue to talk of abstinence till committed, maybe marriage or long living, but whatever it is, abstinence, even secondary abstinence. Even if you're already in a relationship which is physical, you can always look at secondary abstinence. So it's not like an all or none, and that's a good way to go forward, especially knowing the effects on you. Being faithful to one partner, and then of course your condom and contraceptives come into C, and diseases for your STI and STD. So responsible sexual behavior, in brief, like MKC sir would say, involves not hurting another person and not hurting yourself. But we are talking about both physically and emotionally here. So this could be also shown to Abhishek or maybe his parents to get them to understand some of these things if they are in the loop. But basically, you're talking about how he's emotionally very, high, but definitely, and his reward, of being in a relationship is blinding him to all his other goals and his future. And of course, he has poor judgment and he is not to blame. It's because his brain is still developing there. So when you look at these images, they're very useful to show to parents in various contexts, but they're also very useful to show to teenagers. And I usually have a set of all of these on my, teen clinic drawer, which I can just open out and flip through and show, or show it on a screen if you want to, just to make a point or add context to a particular scenario of counseling. So definitely when we talk of, pregnancy, we need to look at normal anatomy, function, as well as your fertilization, cycle, menstruation, and the risk. And the risk is real. And maybe they don't bother to look at it as real. So you need to do something actively if you want to avoid pregnancy, is the message going forward. So contraception, maybe Abhishek had not revealed, but would you like to know about contraception? If he said, yes, this is there, or this is the site you can go to, and you have some access to safer practices. So you're not here recommending that they go for contraceptives or get engaged or get into intimate relationships. Here you're telling them health education, offering what is available and what is recommended. So if you notice here, many boys and girls think condom use is good enough, but it's actually very low here in terms of being least effective versus the injectables and the intrauterine devices being the most effective, even in adolescents, when you look at the efficacy. And whenever you're using barrier methods, it's always good to combine it with either pills or other methods. And if you look at the recent developments in long-lasting reversible contraceptives, they are also recommended for adolescents, mature minors, and they include both implants and your intrauterine devices. So when you look at what you're going to do in terms of contraceptive counseling for adolescents, of course, all this list is here. You can go over it, but basically we shouldn't, feel shy to discuss these things or have it at least for sharing with the adolescents in need. And of course, HIV, luckily for us, HIV gives us an opening to talk about anything related to sexuality. And that can be a good window because it's such a chronic and long stigmatized disease that it's easy to start there and talk about safety. So with that case on Abhishek, I just move quickly to just another case where a police constable brought Aksar, 17 years, for a routine physical examination after he was picked up from his home for a crime. He wanted clearance for locking him up into the observation home for boys. This home is a home for juveniles in conflict with law. And the crime he was accused of was that he had kidnapped his girlfriend Ankita and taken her to Mysore. Ankita, 1 year younger to him, is his college mate, first PU and he's in second PU. And they are in a relationship for 3 months. And Ankita's parents have filed a police complaint. So the policeman, Aksar's mother and Aksar are here in the hospital for a checkup. So can you understand this scenario? So some legal aspects, we need to educate ourselves. Consensual sex or permission or consent for sex in our country currently is 18 years and above. There's a Criminal Law Amendment Act 2013, India, and marriage under 18 for female and under 21 for male is considered illegal. And of course, same-sex homosexual intercourse is no more a criminal offense. There are rules for abortions and MTPs. There we do have access to a free, helpline for children for including sexuality related or abuse related, and the POCSO Act, a comprehensive law for protecting of children from sexual offences, is very clear on a lot of the punishments and fines for various acts against children. So when you look at the POSCO Act, age of consent under POSCO is probably the highest globally, and we really had it at 16 earlier, but now it's moved to 18. So there is a problem because it's clashing with normative adolescent development, and a lot of national law school lawyers and NGOs have pitched in to try to modify it for normative adolescent behavior. Is POSCO failing adolescent sexuality and autonomy? Currently, yes. As adolescent stakeholders, where do we stand? So when you look at sexuality education, if you brought out that in a big way, you could avoid a lot of these scenarios, because then you talk about these. You talk about risky sexual behavior, sexually transmitted infections, and it is associated when you do that with reduced risky sexual behavior. And HIV prevention education resulted in delayed age of intercourse, reduced number of partners, safer sexual practices, and contraception. So it is 100% proven that sexuality education does not abet early sexuality. So if you look at in this scenario, this girl was 16, he was 17. So it's only considered abuse if the child does not fully comprehend, is unable to give informed consent, violates the law. But here both are under the same age group. And the activity between a child and an adult or another child, at least separated by 3 years, would what comes true. But this doesn't matter because this boy was already in the police custody. So you can imagine here how we are being unfair to this family who could best serve the child's, both those children's purpose by sitting together and sorting this out in a non-court setup. So more about the problem, he was in a consensual, in fact, it was Ankita who wanted to go to Mysore, okay, because she had fought with her mother and decided to go with Aksa to Mysore, and he was ready to die for her, so he took her to Mysore, and of course they engaged in whatever was, forbidden sexual activity, and he had a single working mother, father was no more, and to add, salt to the wound, he was a Muslim and she was a Hindu, and it was a mess. So basically, he was an average student, very clear. He wanted to be an Uber driver, and he was confident of starting off just 1 year ahead when he gets his license. So, when you look at this situation, you understand what I'm talking about. So you, as a pediatrician, have multiple roles. You need to screen for emotional problems. Akzar and the girl, we don't know where this goes. So a lot of emotional problems, STI, pregnancy prevention, all of this you need to do. But you need to educate not only on sexual development, safer practices, ABCD I've gone over. You need to be a counselor for them, the client and the parents, and maybe here even the authorities. And as a pediatrician, many times we advocate for children, advocate for immunization, advocate for nutrition, breastfeeding. We need to advocate also for adolescent sexuality. So Kavita, 17-year-old, presented for routine vaccination, HPV, and she just revealed very casually when I did my heads that she's a lesbian in a relationship. And she has no problems about it, no confusion. She's doing very well in school. In fact, she's in her 12th grade and she's the captain of her basketball team. And she actually doesn't want to discuss about it. She's very comfortable. So here, what do you do? So basically, our knowledge on gender identity, where, I feel like a girl or a boy trapped in a boy or a girl's body is what you have gender identity issues. When it starts getting very distressing is when you have an identity disorder. Orientation, of course, your preference for sexual expression towards the same gender or opposite gender can put you into straight, lesbian, gay, bisexual. Some of these terms are also expanding and fluid. And biological, of course, talks about what you are, genital, internal and external, and some intersex disorders can get mixed up here. And gender presentation is the role or the projection that you make to the society based on what you feel is appropriate. So we need to understand these terms, and we also need to remember that sexual orientation and gender identity are not a choice. Many are established by early childhood, and they're shaped both by biological and environmental influences. And the terms are expanding, and we need to be abreast. And the terms are not necessarily what we know, it's what the adolescent brings to your table too. So counseling on health, hygiene, safety is what Kavita needs. She needs emotional support and follow-up, assistance to come out when ready. She is not ready, of course, to talk about it at all to her father. She's recently lost her mother. And in fact, she is carrying the guilt of being blamed by her sister that her mother had a hint and therefore died of a cardiac failure, a cardiac, heart attack or an MI. So she is carrying the guilt of maybe her mother had guessed and therefore, had this problem. So that's the counseling scenario for Kavita. So material, of course, these are old materials. They may be newer, better ones. I know that there is a lot of sexuality education material even in the school education curriculum of your CBSE board. So NIMHANS has some. So it would be good for us to decide what works and share it freely. Thank you.
Thank you, ma'am, for this gripping talk. And Raghavin sir, are you there?
Yes, Dr. Shilpa, I'm here only. Yeah, it was a very nice, fluid, and a very interesting talk. And there are a lot of issues that we'll discuss after both the lectures are over. So I definitely see that there are many questions, and many viewers want to have multiple questions for they want to clear them. So we'll go ahead with the next lecture, Dr. Shilpa, or we will have questions now. After the second talk, no?
We are honored to introduce our next chairperson for the talk, Akash Lalwani, a leader in the field of pediatrics for exemplary service to neonatal and child health in Chhattisgarh. He is a state coordinator for NRP program and trainer of many national central IAP programs. And I would like to invite Dr. Akash Lalwani to share his valuable thoughts with us and introduce our next guest speaker, Dr. Vinayak Koperde, sir.
Good evening, Dr. Shilpa ma'am, and good evening to all the eminent members here. Am I audible to all? Am I audible to all?
Yes, sir. Yes, sir.
Yes,
You are
yes.
audible.
Yes,
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 sir.
Thank you.
Akash.
Thank you. So, with all my hearts, I would like to invite Dr. Vinayak Koperde, sir. Dr. Vinayak, sir, is a developmental pediatrician. He did his MBBS from PTJNM Medical College in 2008. Did his MD Secretary from NIMHANS. He did his postgraduate diploma in Child and Adolescent Psychiatry, Edge Hill University, UK, and CAMHANS Fellowship, NHS, England, 2020. Dr. Vinayak did his DM in Child and Adolescent Psychiatry from NIMHANS in 2017. Presently, he is a consultant in Child and Adolescent Psychiatrist, Springboard Child Health, Belagavi. He is consulting Child and Adolescent Psychiatrist, Child Development Center, KLES, Dr. Prabhakar Kore Hospital and MRC, Belagavi again, and Associate Professor in the JN Medical College, Belagavi. As far as the awards are concerned, Sir has received Dr. M.V. Govind Swami Award for Best Outgoing Student. He was a gold medalist there in DM Child and Adolescent Psychiatry 2017. Best Resident Award was also received by him in MD Secretary for the year 2009 to 2012. Regarding publications, there were 10 publications in national and international journals by Dr. Vinayak Koperde, sir. And the areas of interest are autism, adolescent mental health, and psychosomatic disorders. I would request Dr. Vinayak Koperde to deliver his talk on dialectical behavioral therapy, and I would request all of you to be patient and listen all the aspects of the behavioral therapy which he's going to discuss. Over to you, Vinayak, sir. Thank you.
Thank you, Dr. Akash. If you can hear me all, I'll just share my
Yes, sir.
presentation, and hopefully
Sure.
it's visible to everyone.
Sir.
So first of all, thank you, Dr. Akash, for the kind words. Dr.
Pleasure.
Kavita, Dr. Preeti ma'am, who have been phenomenal in conducting these sessions, which have been helpful, which I can see from the participants and participation. So the topic which I'm going to look at is dialectical behavioral therapy, and we'll try and see as to how we can see this topic as to first to understand what do we mean by dialectical behavioral therapy, what are the various strategies with some examples, and as a clinician, what are the things we should be knowing about it. So to look at the origin of the dialectical behavioral therapy, it was first conceptualized by Marsha Linehan when she was working with adults with borderline personality disorder. When we talk about borderline personality disorder, these are the individuals who have difficulties with impulse control, severe anger or emotional outburst, up and downs of emotions, and recurrent self-harm. Over the time, the DBT, dialectical behavioral therapy, has got expanded because there was increasing evidence through studies that even it can be helpful for adolescents who have emotional and behavioral dysregulation. So, what are the indications in which DBT has been found to be useful? Adolescents who have suicidal ideation or suicidal behaviors. So, adolescents who are attempting suicides, and then there is non-suicidal self-injury. So the intention to harm is not to end the life, but there could be other reasons why an adolescent will be self-harming, just to soothe, just to distract, just to gain sympathy, or there could be a lot of other reasons for which the adolescent could be self-harming. The other indications like eating disorders, trichotillomania, externalizing disorders by mean a lot of impulse control disorders, impulsivity, aggression, mood disorders like depression, bipolar disorders. So these are some proven conditions in adolescents where DBT has been found to be useful. So what are the theoretical foundations? Where has it come from? But DBT is nothing but a form of cognitive behavioral therapy, but has inclusion of mindfulness practices and some acceptance techniques. We'll see in detail about what are those. But what is the meaning of dialectical? So dialectical or dialectic is nothing but balancing and integrating opposing forces or perspectives to achieve more effective emotional and behavioral outcomes. To just give an example, the dialectic means there are two minds, there are two voices in everyone. So am I good? Am I not good? Does this friend like me? Does this friend does not like me? So conflict of this leads to problem behaviors and emotions. What we are looking at in the therapy is to accept and change so that a fusion is formed, and combining thesis and antithesis when moving forward to get a positive change in the behavior and thinking. So in summary, DBT is nothing but principles of behavioral science and then components of dialectical theory with the sense of Zen practice, including mindfulness. Just to summarize, behavioral principles in DBT, what are we looking at is challenging behaviors, which could be aggression, it could be emotional outburst, it could be self-harm, which we see as a learned behavior, and try to identify triggers. What are the triggers? The friend didn't talk to me, mom shouted at me, or I had a very bad exam today. So the triggers could be internal or external, and then change the contingencies also. So if I get angry, everyone shuts up. If I self-harm, I get attention of my parents or I get included by my friends. So it could be the consequences. We have to identify the triggers and also identify the contingencies which are maintaining these behaviors and try and see how we can move forward. What do we mean about dialectical philosophy? So in a person, the opposite views can be present at the same time. But when these are not synthesized, they result in a conflict. By conflict, we mean emotions are stirred up and behavior is haywire, and that reflects to us in therapy. What DBT does is it tries to work to resolve this conflict by accepting and understanding and moving forward. Coming about an example of dialectical approach before we go on to exact strategies. A young person is struggling with a self-harm. In DBT, the dialectical approach would involve balancing the acceptance of the current feelings and actions with the need to work towards reducing self-harm with the help of coping strategies. So acceptance means a DBT therapist would start by acknowledging and validating the current emotional state. The adolescent is quite emotionally charged up when the adolescent is self-harming, and the reasons behind the self-harm. So we completely acknowledge and understand and validate and say to the adolescent, this, yes, I understand where it is coming from, where you are coming from, why this happened. For instance, you are using this self-harm to cope with your intense emotional pain. And then the therapist would recognize and try and reduce these harmful behaviors so that a purpose, this can be replaced by other behaviors where the person can get a sense of control. After that, we're also looking at change as to, while acknowledging and validating the feelings, the therapist wants to inculcate in the mind of the adolescent as to how, instead of maladaptively behaving, what are the strategies which we can use when we get angry, when we get emotionally disturbed, and instead of self-harm, what is that which we can learn and help us. And this integration would lead to acceptance and change. DBT by such is not just an individual therapy, individual in the sense one-on-one therapist and adolescent, but it has other components also. Individual therapy, there is skills training in groups, so group-based therapy, and then there is telephonic coaching to the adolescent, and then there are therapist team meetings. So mind it, therapist team meetings are nothing related to adolescent or the patient. These are among the therapists who are seeing the adolescent to reflect on what's going on in the therapy, what is going right, what is not going right. So understand and change that. When we talk about individual therapy, that is therapist and the patient one-on-one. Usually these are weekly sessions lasting for usually 6 months to 12 months. But in practical, these are a little difficult to have, but there are good number of adolescents and adults who come, who stick to the therapy, learn and get better. In the individual therapy, we're looking at identifying and analyzing the problems. In this, we also ask them to keep a daily record of their mood. Also, what are the problem behaviors they have displayed in last 1 week, and what are the newer ways they have tried in learning and how they have tried to manage it. Then we work with the adolescent to build skills to manage these distressed emotions such as anger, frustration, sadness, and impulsivity. So what happens in in individual therapies, the core is what we call a dialectical strategies. Here, the therapist works with the young person to change maladaptive thoughts or behaviors. Therapist and young person discuss an alternative viewpoint about any event. For example, I was upset about the friend not talking to me. So she just looked at me and went without waving or without talking. That led to a lot of sadness and anger, aggression, and self-harm. So what are the different perspectives which we can bring in? Whether the friend was busy, she had some other issue, she was troubled in her own mind, she didn't look at you. So there could be a lot of other perspectives which also need to be considered. And then encourage to see how we can, these opposing views as to the thoughts are friend doesn't like me, that's why she's not looked at me. But there are also one mind saying that friend likes me, and at times she pays attention to me. How we can synthesize these two opposing views is what the dialectical strategies is meant for. There are some strategies when we talk about dialectical behavior therapy as to playing devil's advocate. In devil's advocate, imagine an adolescent has come with a complaint that there is in my classroom, we have a project and there are 5 people, and apart from me, all 4 others are not at all being helpful. And that is causing me depression and feeling a lot of sad and emotionally upset. So how this example can be used using the devil's advocate analogy is maybe you can introduce this to the adolescents saying that we are going to see this example by or you can say that we're going to play a devil's advocate, and in this process I feel that you've been really upset, and we'll see what are the other perspectives which we can get using devil's advocate, playing devil's advocate. So in this, imagine someone was arguing that your group members are actually working hard and you might be missing something. Then what could they say? So actually the adolescent has to switch the role and they have to argue for the other 4 people who are actually doing well. They're trying their best. So that is one way of getting different perspectives. In the process, the adolescent may come up with various explanations as to, yeah, all of them are in 10th grade. They may have their own emotional problems. They may have time constraints, they may be upset. So it helps build different perspectives to about a problem. The next strategy is that of use of a metaphor. It's another engaging way. Adolescents sometimes use various terms like, I feel as if I am drowning, as if I am in a pressure cooker, as if I am going to break down. So using this metaphor and making the adolescent build it up onto, if when you are drowning, what are the things you can do to float across? What are the things you can get help to come to the surface? So the adolescent may bring up some ideas as to, I can talk to my friend, I can talk to my parents, I can get this help. Using of metaphor is another strategy. Then making lemonade out of lemons. Here, therapist takes a problem and tries to turn into something positive. Adolescent who is struggling to complete her maths homework is the problem, can be seen as a lemon here. The therapist tries to put this idea into the adolescent's mind as to how this can be an opportunity for developing new skills, or this could be an opportunity to build up your strengths. So the adolescent may come up with an idea as to, maybe I can form a group of my classmates who are also struggling, and we can discuss each other's problem. Or maybe I can talk to the teacher who would help me actually to understand the concept better. So these are the, so in this problem, actually the lemons have not disappeared. The problem is still there, but you are learning new strategies or trying to overcome these challenges by building your strength. So that's another way. Then there are validation strategies as to throughout the sessions, the therapist actually validates and understands and does not say at any time that, why did you self-harm? Why did you behave like this? Why did you get angry? Okay, the therapist always tries to validate the emotions. I can understand why you might have done this. I can understand how much painful it might have been for you. So the validation strategies are equally important. Then there are some problem solving strategies in individual therapy where we select a problem. It could be of self-harm or aggression and try to do a behavioral chain analysis. There are various steps involved. We'll try in the next example. So to start with the situation, for example, the adolescent had exams, was awake late at night and did not have dinner. What was the antecedent event? She entered the kitchen and mother commented that you left the dishes unclean, you left the plates on the sofa unclean once again. That leads to triggering thoughts that mom can't understand my condition. I have exams. She's still behind the dishes. And it also leads to emotions. Yeah, it's I feel guilty that I have not been able to do that. I feel angry that, mother can't understand me. And then the behavior. What was the behavior? That I push the cups accidentally, it breaks. It leads to consequences that mother shouts more. You can't do a simple thing. You always do it intentionally. So that leads to, again, thoughts that I always mess it up, and shame and anger, emotions. After mother shouting, that is the target behavior for us. So the adolescent has not come with all these 5 antecedents, but only the target behavior, that is self-harm. So after mother has again shouted, the adolescent goes and maybe cuts the wrist or takes paracetamol pills to reduce the emotional pain. The intention was never to die. So what has happened after the act? It has calmed down the adolescent. The mother also comes back and asks as to, it's a little difficult for you. Sorry, I should not have said that. So that's how the chain. We are looking in behavioral chain analysis as to where can we cut this chain, so that a similar situation arises next time, it doesn't lead to self-harm. So it could be handling the vulnerable situation, like, being awake late night or not having dinner, or it could be how to communicate with the mother who is angry about dishes, or behaving, learning some other coping strategies. And after the problem solving strategies, we always come at solution analysis as to what are the solutions which can be brought in to cut this chain, as to what are the responses you can have, mother can have, the environment can have, which would help us. So after the individual therapy, we come to the group's skills training. In the group skills training, there are 4 components which are important. The thing is mindfulness, other one is distress tolerance, third one is emotional regulation skills, and fourth one is learning interpersonal effectiveness. When it comes to mindfulness, it's the practice which is derived from the Zen practice, and it implies that to be in the present moment, doing one activity at a time with complete attention and acceptance. So there are 2 steps. First step is training the adolescent to focus on the present moment, paying attention to whatever the young person is doing, reading, talking, walking, listening to songs. It can be done in the therapy session as well, where the adolescent is asked to pick up a book or draw or make color or just think and reflect, being aware. Do not attach any meaning. Don't think about past or future. Don't see how you're feeling. Then the second step. Second step is acceptance. Just be aware of experience and not judge it. So if the young person is feeling anxious, they try to simply accept it first. Yes, I'm reading this chapter, it is difficult and I feel anxious. That's it. So then we need not attach the stream of thoughts to it as to how am I going to complete this chapter? What's going to happen to me in the exam? So the future and past does not have any role here. It's mainly about present, now and here. So this is coached in the therapy sessions as well. First step being awareness and second one being acceptance. Adolescents can understand mindfulness a bit if you can give them the analogy of monkey mind, that the mind is like a monkey and it goes on jumping from one place to other, gets easily distracted and trying to see different things, and it's like holding the monkey back and putting your energy on the present. There are various other practices which can help initially to improve the mindfulness practice, such as counting breaths, observing an object in the environment or a sound, focusing on a thought without judging it, etc. So count the breaths, reverse order, or as 1, 2, 3, 4, or observe an object, what you see a picture or a photograph and try to describe it. How is the frame, what's there in the picture, and then focus completely on it and describe it. Similarly, a thought. I have this thought that I am reading and this chapter is difficult. So just being in the present moment. The next set of skills is learning distress tolerance. These are skills which are taught to the young person to control impulses. Quite commonly, adolescents would have lot of emotional outbursts, impulsive shouting, screaming, hitting, self-harm, aggression, going away from the home, rash driving, substance misuse, sexual encounters. So these could lot be impulsive in nature and as a result of distress. So at this time, we can use this acronym RESIST to understand how we can go ahead in the therapy. As to first is reframe the problem by giving a different perspective to the problem. So with that, we've learned in as to dialectical strategies, and then engage mindfully in an activity at that time, and then do something for someone else, like visit a friend who needs help or spend some time with the family member in the cooking or helping mother. Then there are intense sensations that how can the friend do this? How can I get so much less marks? How can this? So that creates a lot of anger, upset, sadness, and frustration. So how can we distract from that? You can wash face or take a cold water shower, put a rubber band or wrist and intermittently snap it. So instead of self-harm, we're giving them alternate strategies. Hold or chew some ice cubes, go out of the situation, walk some distance. So these are strategies to distract from that emotional pain. We know that whenever an adolescent self-harms by cutting or taking pills, it gives a gush of endorphins and other good feeling hormones. So that could be a maladaptive way. But here what we are doing is trying to replace that activity with less harmful activity. And then think about neutral thoughts such as can you listen to a song or pray or say some mantra like calm down or shanti or whatever the culturally appropriate thing for the adolescent is. Then emotional regulation. As the adolescent is developing, the brain also is taking shape. And we know that in this process, there is a lot of emotional dysregulation as part of normal adolescent development also. And that identifying emotions in any situations as to how are my emotions with any event is very important for the adolescent. And then is the adolescent able to identify it, describe it, and determine as to how I express after that emotion event is important. And these in this process, a lot of self-validation. Yes, I feel angry. Whenever this happens, I get upset and increasing my positive emotional experiences. So I do things which make my, so it's like, balancing your mind with more of positive emotions and which are acceptable. Like I go out for a walk, I like to listen to music, I play a guitar, I go out and play in some sport, or I go outdoor to meet friends. So that makes me happy. That makes me feel confident. So increase the positive emotions and suppress the negative emotions is what we're trying to do. The half smile is another strategy where it's a saying where, sometimes your joy is the source of your smile, but sometimes a smile can be the source of your joy. So the adolescent is asked to put a half smile. It's a simple DBT skill. The young person is coached to slightly, put a half smile on the corners of mouth. And this half smile expression will help increase positive emotions. So that's another strategy which can be coached to the adolescents. The other skills for emotional regulation, WATCH is the acronym. Watch your emotions. What are the physical sensations, also your thoughts? What are the memories you are getting at that moment of time? Avoid knee-jerk reactions. When I feel angry, I shout, scream, hit, go, so avoid. And then think that overwhelming emotional experiences as a wave. It will pass, it will go away. And choose to let yourself experience the emotion, which will help in the long term. As to, I calm down and later express, or I talk to someone else. Then see these emotions as your helpers. They will help you in navigating the life. The last one is interpersonal effectiveness skills. Many a times the reason for conflict and problems is interpersonal difficulties among adolescents, with adolescent and parents, adolescent teacher, or any other person in their life. In this process, assertiveness skills is something which would help the adolescent to improve their relationship. So the young person can make a request in a gentle way, which will not harm relationships, can describe the situation. For example, an adolescent is asked by the classmates or close friends that, let's go for a movie tonight. The adolescent has exams or is not prepared tomorrow and does not want to go, but feels scared that doesn't go, she will be, thrown out of the group, or what the other adolescents. So in the process gets a lot of emotional ups and downs. Here, the adolescent can, describe the situation. So what is the situation? See, I would have really liked to come with you. I would have enjoyed the movie, but it's just that, my assignments are incomplete. So can we plan it some other time? So these are, the adolescent is putting it across in a respectable, accepted way, instead of, saying just no, which can be taken as a little disrespectful. Or asking for more information. If someone has asked you, you're going to complete this assignment today, that, the mother says it. And adolescent is completely confused as to why today, there is a whole week left. And suddenly, instead of shouting and screaming, I'm not going to do it, or why should I do it today? There's a whole week. Asking for, You're saying this to mom, you're saying me to complete this assignment today, but still there is one more week left. What is that am I missing? So can you tell me? So mother has some other plans. So mother will come up and say, possibly next 2 days we are going out here. And after 2 days, this is happening. So maybe you may not get the time. So ask for more information whenever there is a demand, and that would help communicating effectively. And gentle manner, sorry that I can't join, sorry that I would not be able to do it. Gentle manner is the way. So the other notes is telephonic coaching calls where the adolescent can ring up the therapist whenever they are having self-harm urges. These are usually brief 5 to 10 minutes calls. Everything can't be advised on these phone calls, but the therapist can direct the adolescent as to, can you use this strategy now? Can you do this? So it's a brief call. It can't be for a long duration. And that has to be said in the beginning only. And then therapist team meetings to reflect. The many therapists sit together, discuss and think and talk over about the problems as to what can be more helpful. So the key points is in dialectical philosophy, there are opposing views in a person at the same time, which can result in conflict, and we're trying to resolve this conflict by acceptance and understanding. And it's a form of CBT where there are mindfulness and acceptance techniques. It's a multimodal therapy. Many times we resort to using only individual or whenever possible, the telephonic coaching, and so in some formats, the group as well. 4 pillars like mindfulness training, distress tolerance skills, emotional regulation skills, and interpersonal effectiveness. These are the 4 pillars of the DBT. With that, I think I should stop here. Thanks for giving me the opportunity and patient listening. Thank you. Thank you very much.
Thank you so much, sir, for an excellent and elaborative talk. Actually, we in our day-to-day activities or in OPDs, we are well aware of the fact that adolescents these days have turned out to be emotionally labile. So all the efforts which you have guided us, it will be really fruitful for everyone to practice in their day-to-day OPD practices as well as in the hospitals also. So I request everyone, Dr. Shilpa ma'am, shall we proceed for the questions?
Yes, yes, please. Carry on. You and Dr. Raghavendran can take it.
I think we have started first lecture with Dr. Chitra ma'am, so we'll put first to Chitra ma'am.
Yeah, sure, sir.
Dr. Raghavendra, Chitra has answered many of the questions in the chat box actually.
Yeah.
So if you wish, you could just kind of answer what she's, Can you be a little louder also, Dr. Raghavendra? They're not able to hear you.
Okay, now I'm audible.
Yeah, you're audible. A little louder would be better. So, she's answered
Chitra,
most of them in the chat box.
Yeah, she's here.
Yes, I'm there.
Yes. So, ma'am, one question is from Dr. Sangeeta Joshi Bilaspur, Dr. Sangeeta Joshi, ma'am. So, once we have taken the adolescent into our confidence that we are not going to reveal anything to the parents or anybody else, but how do we counsel the parents, or do we need to talk to the parents separately regarding the adolescents, this romantic relationship or his behavior?
So, sir, what is the scenario? Is it required for you to talk to the parents at all?
There might be situation like child is going into physical relationship with the other gender, then.
Yeah, so that is their choice, right?
Yeah, it is their choice.
So what I'm asking is, basically, we have to be identifying our role here as health providers, okay?
Yes,
as people in charge of taking care of the health, hygiene, safety of the adolescent. And we are in trust with the parents because they have brought the child for this. So we are clarifying before we talk to the child about things related to sexuality and personal choices, behaviors, that the parents are in the loop that what we are going to be talking with the adolescents is completely confidential. Otherwise, they will not even come out with what is the problem, which you may have powers to actually solve or help with, right? So they understand that. And they also know that you will not be talking to them at all without permission of the adolescent. So the adolescent, basically, if it is a situation of abuse, if it is a situation definitely which is inappropriate, developmentally or otherwise, if there is a connotation of safety concerns, health concerns, which are very stark and genuine, at that point, keeping the adolescent in your side, you know, he or she can take your help to break something to the parents, right? Example, if they are cyberbullied, if they are having some kind of a blackmailing emotionally happening because of shared pictures, videos, threats, so many things go on in the context of sexual relationships in teenagers' lives. So if they have something which they are not sharing because of stigma, shame, you could help to share that with their parents so that they get the help for it. And they're out of their emotional difficulty and, you know, proceed even further with the cybercrime reporting, etc. So many things you can help with if you keep that confidentiality and partnership with the adolescent. You will break that if you just go straight off to, inform the parents about what, I'm not sure. So what we have to know is what our role is, and where we are looking at is only the concern or focus should be on the health, hygiene, safety of the adolescent.
So
in
we
that
are
context, whatever needs to be done, you will do, including informing the parents.
We are definitely not bound morally or legally in explaining the condition of the child to the parents. We are not bound.
Correct, correct. Because in that case, you will not even be allowed to be their care provider anymore, right? Because they will not come to you also.
Right, ma'am. So now there is one more clinical scenario which has been provided by Dr. Umesh Khurana, sir. So there is a child, there is an adolescent girl who has been chatting with his boyfriend over for last 2-3 months, and now her academic performance has been going down. Now when their parents came to know about it, they want to snatch her phone. After few counseling sessions, the child has improved. Now she is better. But is there any additional expert advice that you would like to give in such a scenario?
So I don't know what is the level of the, relationship or the media being used only to chat with the boyfriend. What was the, the details of the case. So what I'm trying to say is counseling helps a lot, but let's just define our roles. We are here to help. There is a dysfunctional, sleep routine. There is a problem with grades. The same thing as Abhishek's scenario, right?
Yes, ma'am.
So we are not encouraging or discouraging or doing anything to, advise. But what we are doing in the counseling is to help the adolescent get insight to get out of their dysfunctional state, which has happened in this case. So whatever counseling was done looks like it was very effective, which is great. And, in terms of keeping the adolescent healthy and safe, whatever preventive counseling and health education needs to be done should be done now. Because this is not a one-time thing, right?
Yes, ma'am.
Yeah.
And similar question has been asked by Dr. Parimala that what if any adolescent wants to have a physical relationship and he or she cannot control the urge, how should they be counseled?
So I guess you can ask them what they do because obviously you can't just, have a relationship when you want. The other person the limits are there, the boundaries are there. Maybe you've defined it for yourself. So what do you normally do to distract yourself and, how you engage? So I think a lot of these answers come from the adolescents themselves. We are here to just guide them. Maybe what works for one may not work for others. So it's just, I don't think they come really to doctors to ask about things like this, where you need to, advise them. But if they do have some kind of difficulty, you can ask, what can you do? And you may get the answers and learn from that to help out others who may be wanting options, So
Yes,
definitely engagement in sports, self-stimulation, and then, having some kind of a distraction, like what sir already mentioned. There are ways of, changing your thought process to in a direction that distracts. So anything that suits that adolescent scenario could work.
There is one more question from Dr. Sangeeta Joshi, ma'am, that does talking about the oral the contraceptive methods gives a positive indication, positive signals about getting into the actual act?
So that's what studies have shown, no. So that's all I can say. I just shared two very briefly because the time was limited, but there are extensive studies confirming without doubt that information on sexuality does not predispose to early or risky sexual behaviors. So there is confirmed evidence. So with the evidence, I think we have no basis of withholding normal sexuality related education from our young. And so we should advocate for it as a group, maybe as adolescent chapter group, for inclusion. It has to be done right. It has to be done in a way that is friendly and culturally acceptable and societally permitted. So of course, we are intelligent enough to do it that way. So I think that's a good way to move forward.
And your
With
thoughts
evidence.
on homosexuality, ma'am?
There is no, I think that is one of the components. Orientation is one of the components of a sexuality development. And so it's kind of established that there are biological, environmental factors. There is there could be, experimentation with it. There could be changes in it. It could be established, or it could be something that evolves into something different. So I think what we need to do is get the perspective from the adolescent's point of view again. Like, okay, you're in this relationship, so why do you think it's special? What do you feel you're getting from this? How do you see yourself? There are a lot of names and terms and things that we learn because they have different terms to share with us. And also, how it is impacting you as a person in your tasks, which may be studies or games or relationships or parents, relationship with the parents. These kind of things are what we would be focusing on rather than the act of whatever they are in. And many of them would just want that support. They are not here to ask for any guidance. And if they're confused, they will tell you they're confused. And where you can use your knowledge to share that, yes, that's kind of normal. I understand how you feel. And there are, because of what we read and say here, and maybe peers share, you may feel sometimes that, you are this oriented this way, but we don't know. So give a window of fluidity to whatever they're going through and say that whatever happens, you're there with them. That would be more useful because they know who to come to and maybe take guidance from. And I think we all need to read up a lot about various aspects of sexuality, because we ourselves are constrained by the limited knowledge we have on actual behaviors and the dimension of fluidity that we have.
Right, ma'am. So other questions probably you have answered in the chat box only. So I won't go into the details of other questions.
Yeah.
So thank you, ma'am. Thank you so much.
Thank you.
For your.
If you don't mind, can I ask one question, ma'am? Last one question. I'm Radhika.
Yes, ma'am. Go ahead.
Sure, ma'am.
I have an ethical dilemma about the same topic. I saw a 15-year-old girl case in the last year. In that case, if I explain you briefly, that the girl was having physical relationship with her classmate in the school itself, like unused room. And when mother went with some problem to the gynecologist, this girl also privately talked to the same gynecologist about these issues. So whatever she counseled, we don't, the parents doesn't know. And because of the maybe confidentiality, this thing, the gynecologist didn't inform anything to mother. But after that, it continued, and the girl allowed the boy. They used to keep so much safety measures in the house, but in the midnight, the girl used to switch off all the safety measures and invite that boy to the house, and they used to have physical intimacy frequently. In that process, one day there was a big robbery in the house because their parents felt that they locked everything, but in the midnight, this girl opened it, and a big robbery happened. And after some time, all these things came out. When they approached me, they told all these things. By the time, they already know about all these things. So my question is, in this scenario, in general, I am asking that how confidentiality as a professional, of course, it's not our responsibility, but overall scenario, if the doctor indirectly or directly anyway, if warned the parents or counseled the parents, so that robbery would have averted. Or, I'm in a confusion. Please guide me.
So, ma'am, is that question for me?
Yes, ma'am. I was asking.
Okay. So basically, what I see here is ma'am, adolescents are engaging in sexual activity. That is the truth of the matter, right? Some come to light, some don't come to light. Some are clever enough, some are not clever enough. Some problems happen which because of this, which can be very serious and very bad. So I think our role is what I already clarified. I don't know, we don't generalize, right? So in this particular, maybe there were a lot of the fact that she took so many risks was very obviously she was not following whatever safety maybe, or she had got very bold about many of the actions that she was taking. And I'm not too clear whether she got good preventive sexuality education, some insight, some good counseling related to borders, privacy, boundaries, things like that we already discussed. So maybe that's where the prevention comes. Not informing parents maybe right away. But if you feel those things are breached and she's in a state where she's going to be at risk for herself because of the risk she's taking, or for others because of the risk she's taking, at that point, definitely with her permission, you would talk or reveal things to the parents. So I'm not saying that it's like confidentiality at any cost at all. So I guess we do our first job first and then move forward. And at any point when we feel as people,
convincing the child to child for that to inform the parents and talk to the parents is better middle way, according to you.
let the child decide, no ma'am. I don't know, because there are some girls who may get killed. Okay, we have all extremes. We have very strong family values. We have honor killings. We have children shut off from school. They're stopped from school or college because of inappropriate relationships. Okay. So we don't know the consequences of our information. I think if we don't know that, it's dangerous to reveal like that, right? So that's the other side of it. So children are, example, in that case, Aksar, I told you, he was put in that home and beaten up. Okay.
Yeah.
So a lot of consequences are there for children. I don't think we are advocates for the child, right? At the same time, we use our role appropriately when there is a risk for health or safety. That would be my message here.
Thank you, ma'am.
Dr. Vinayak, sir, there's a question for you here. So as far as DBT therapy is concerned, how to deal with an adolescent with an autistic behavior? So if an adolescent is having autism, how to deal or how to explain the DBT in that child?
I think if an individual or a young person has autism, make sure that their intelligence is good enough. So normal intelligence, you can adapt DBT skills to some extent. Where the intelligence is subnormal, then better not to go, because it requires a lot of understanding of consequences, understanding how therapy is going to work. So they can have difficulties in the group format, for example, social anxiety, changes in the routine, and managing people around in a group. So you may have to modify it a little bit, but I don't see any reason why it can't be done for individuals who have good intelligence. Though the studies are not many, the evidence is slightly building up, but we are not there yet where we can say that yes, use it as a blanket for everyone.
Okay, sir. Thank you so much.
Thank you.
I hope all the questions have been answered by our respected speakers.
Vinayak, I have one question. So
Yes.
what are the contraindications apart from what you said, low intelligence and, not understanding, having social anxiety? Any other contraindications for DBT where we should not use at all?
There are not many contraindications as such. Someone with low intelligence, someone with organic brain disorder, like epilepsy and personality changes as a result of epilepsy, and someone with severe antisocial traits. So that is where you would want to not do DBT as a first line. Even though some components of DBT here and there may be advised or may be helpful, but these are the things which I think we should be careful about.
Thank you.
Sir, I have one question.
Yes.
Sir, today's generation, they are like not prepared for taking the responsibilities. So does this or DBT have in those cases also? Like most of the adolescents are not ready for taking, men are not ready to earn, females are not ready to do the home course and all. So does it have there or not?
And no, I think DBT has very specific indication as to mood dysregulation and self-harm. Individuals going through these kind of emotional disturbances is something which we look at through DBT. As such, it's a long-term therapy, 6 months to 1 year. Have to be patient enough, have to be attending, have to be dysfunctional enough to understand that this is something which I should be learning and helping myself to change myself. However, when it comes to issues related to adolescents not listening, not doing household chores and other things, I think it's important that you have to bring this culture starting from childhood. When the child grows up 12, 13, and then you expect them to clean up their room, put their waste and help in cooking. So that's not going to be helpful. So we say that start it from the beginning. Involve the child right from the beginning to help with these activities.
Thank you, sir. Thank you.
Thank you.
A couple of more questions I noticed. Exhibitionism. Chitra, your thoughts on that?
Exhibitionism.
Yeah.
I'm not too sure what it means. It's the way of dressing, maybe? Is that what?
Oh, no. Exposing genitalia.
Flashing.
Flashing.
That's
Yeah.
the term that, yeah. So,
Yeah.
meaning you're talking in what context? Because these are just
Yeah.
terms.
How do you deal with such? If the parent comes that, he's been
Yeah,
caught flashing and also
That's
how do you counsel?
Okay, so why is this teenager doing this for what do they see as rewards for it? Do they see that as a way of expressing their power or strength? So I don't know what maybe need to talk to the teenager maybe to understand why is it or what drives them to do it and what do they think they get in return. So is it just a thrill? Is it just the or is it very important for them to show themselves off? So I don't know. In terms of nature, I do see exhibitionism in the male of the species to attract the attention of females, whether it's birds putting on the dance or all kinds of antics. So I don't know if there's something instinctive or something which is there. I have no idea. But like I said, we need to explore within societal norms, right? As of now, this is against the accepted social limits of expression. So in that context, I think we have to look at it and look at how it can be overcome. But I really think there's a lot of variation in how people seek sexual gratification and feel to express themselves. So we need to be open and not be shaming anyone. And we need to try to counsel them out of whatever is outside the norms.
MKC, sir? Sir, your thoughts, sir?
What? Exhibitionism?
Yes, sir.
Or something else?
So you can also give your thoughts on all the sessions. But first, I think this is something which people have asked, 2-3 people have asked.
Exhibitionism as a medical problem, it is to be seen by, I think Dr. Vinayak would be the ideal person to give the answer for that. But when you talked about a child adolescent, it is almost always, it is not a serious medical problem. It is much more of their inability to express their emerging sexuality. I'll give you just a story that will explain most of it. I had a mother who came to me saying the day before, she was changing dress. Husband has left her. So son, only 16-year-old boy and her, and suddenly she found some noise behind and he was actually videoing her changing dress. Naturally, she beat him up and all that, but in the night she felt sorry about it. She came back to me. And for a second, you say you should never feel negative about these people, but still I'm sure I'm telling the truth. For a moment, I also had a negative feeling about it. But once I talked to the child, I found such an innocent child. In his whole life, he has never done anything bad to anybody. So the only safest, but he had to express his sexuality, and the safest person he thought was the mother. And we could really counsel him out of it, just focusing on the point that what you did was okay for the age, but not to any woman of that age, particularly your mother, because that spoils your mother relation with the mother. So he worked on that and it worked very well. It worked very well. In child, I think you need to think it as a developmental issue, not as a medical issue. But I'm sure Vinayak would be able to tell us the classical treatment.
Yes, sir. I think what flashing, which has been described, we've read that as sexual perversions, where exhibitionism, flashing, then there are other means of expression of sexual gratification. But what comes to my mind is whenever there is an adolescent who is engaging into these kind of behaviors, there are two things we should be ruling out. One thing is borderline kind of intelligence, where they don't understand or get the consequences. It's an easy way of attention seeking for them or sexual gratification. Second thing is impulsivity, most commonly associated with ADHD. So they don't think that it's going to lead to me in a problem, or this may not be an appropriate way of expressing. So these are the two things which we should be ruling out first. And then yes, the pros and cons, consequences. So it's not just you're working with the adolescent, but as also with the family as to how they are keeping an eye, monitoring, and letting the adolescent express their sexual needs in an acceptable way. So I think just those few thoughts.
Thank you, sir. I think it was wonderful. I just want to say a few words about Dr. Chitra's presentation. That is a day I felt proud of my old student. She's so confident about her answers. Sometimes I wonder she has done better than me also. That is great. You have done a wonderful job, madam. But however, it's a wonderful day. But however, I need to tell few things, because many of us are getting influenced too much by the Western culture, and we tend to repeat what those people, the so-called Indian Western person. I don't want to name the person, but you understand what I mean. Even if it is from WHO, I think they probably don't understand the internal milieu of this country and the villages. So I think that whenever we talk things, we need to keep that in mind. For example, moralizing, definitely no. I agree with you, 100%. But at the same time, immediately you should say, but at the same time, we should talk about the risk involved. Risk may be to you as well as to the other partner or to society as such, to a family. I think that should be told along with, don't moralize, but talk about the risk. That is very important. Then sexual intercourse at any age, it has consequences. And that consequence may not be, it has legal and emotional consequences. They may be doing on the spur of the moment, and so long as one partner is less than 18, it brings in legal issues. We won't go into details of that. So I think that need to be discussed. The third issue that was about telling confidentiality, telling about parents. Remember three things. We are doing things in the best interest of the child. So whatever is in the best interest of the child in front of you should be the number one. Secondly, we are a citizen who is obliged to go by the rule book. That means the legal aspect we cannot. So third one is the via medium sometimes come. You answered it very nicely. You don't have to tell everything to parent. You may have to sometimes tell for the protection of the child in that environment. So in that particular case also, it's important. The child may be getting into more and more things, and you cannot be the person to take responsibility for that. Child has three guardians. The first guardian, of course, is the parents. The second guardian is the state, not we. And we are only the in-between one, doing a mediator role. That's all. We are not guardian per se. So I think we should not take more responsibility than what we are supposed to take. That's the answer. Now, sometimes it may be important to discuss the cultural norms with the child. I'm not saying you should push that on the child, but the cultural norms also should be, what is the norms in your society where you come from? because child has to be told, because we should not be appearing to be endorsing everything. At the same time, we should never be blaming the child. We should not be adding guilt. We should not be creating problem for the child. That is absolute true. But don't, child should not think that even the doctor endorse it is okay. Because some of these great speakers, great knowledgeable speakers, when they come and talk, it appears as if they are endorsing everything. That is not okay for us. That is the point. And secondly, Vinayak, of course, I was going to ask you a question which somewhat you answered in the summary. My question was going to be, can you tell us in simplest of words, one word each, what is CBT, what is REBT, what is DBT? What is the difference between the three? For a layman, actually it looks all talking about the same thing with subtle difference. What is that subtle difference? If you can explain, that will be great. After all, I can ask only you because you are the one with the DM in, child adolescent psychiatry. So you can't have a better expert. Thank you, sir. Can you give me simple words?
Thank you, sir. It's quite difficult to explain. I'm just thinking as to how to
No,
answer it in one
sir, the
word.
best way would be what is common between the three, and then say what is different between the three. That will be the best approach. All three have common elements. What are the common elements, and what is the subtle difference?
Yeah. So I think common between them is that that behavior, what we're talking about, is seen as something which can be changed. It's a learned behavior and it can be changed.
Okay.
And difference is cognitive behavioral therapy looks at mainly our thoughts. Our thoughts, how they affect our behavior. REBT looks at how our
one sec. So can we say challenging our thought process? Can we say challenging the thought process for alternative thoughts? Is it?
Yes.
Okay.
Challenging and replacing the thoughts will change our behavior also.
With alternate thoughts. Okay. Which are acceptable to the adolescent. Okay.
Yes.
REBT, one step ahead.
Yeah, REBT, it's mostly emotions, how they affect our behavior. Sometimes, emotions are not linked to thoughts.
Yeah.
And I get angry and I just has this behavior. So how we can, rationalize these emotions, learn about those emotions and express those emotions in a more acceptable.
Great. We got it. And DBT?
And DBT would be a mix of CBT and some mindfulness principles, acceptance, letting it go, being in the present moment.
Yeah, I think you are given one very good sentence on that. Not only mindfulness, you had used one more word. Sorry, I just have to take the. Dr. Harinder Singh is here to see me. I'll just take it. Sorry. Hello, Harinder.
I think the other word that you used was acceptance.
Yes.
So acceptance and mindfulness.
Now, I think sir also said earlier that it is to be reserved for selected conditions. Don't try to do everyday cases, start doing DBT, just will be blabbering on that. But I think DBT is to be taken little more seriously, and we need to get training on that before you attempt it, because you're going to use it for the high-end problems, not a lower or middle problem. So I think you need to be little, trained for that. Am I right?
Absolutely. Because it's a very intensive, the population you deal with are like recurrent self-harm, suicidal patients. So that's the risk involved. So if you are not confident and are well equipped with the strategies, then you may feel a little, anxious about it.
Okay. So we should, as a adolescent pediatrician, we should know about it, but better leave to the psychiatrist to do it, or good clinical psychologists to do it. That would be my personal advice, because that's the high end of the problems. Okay, I'm leaving because Dr. Harinder is our own adolescent person. He has come all the way from Punjab. So
Thank you, sir. Thank you for
Thank you so much, sir.
Thank you. Thank you.
Thank you
sir.
so much. It's a pleasure to have you
Yes,
all.
sir. Thank you.
Thank you, Chitra. You were so wonderful. Sexuality, one of my pet topics. You have done so good.
Thank you.
Yeah. Geeta, how are you? Mhm.
I'm fine. I'm
And I
fine.
should
I
really
think, thank
appreciate
you.
Vinayak also and the clarity has given on the psychological issues. It is very difficult subject, especially to deal with in India, with a country like ours, to talk about sexuality, what is right, wrong, how to counsel. So I think time again, the times are changing. We may also have to change our ways of counseling, maybe. But you were so good. It was very professionally spoken. And I hope we all do justice for young people. Very common problem, na? Love affairs among adolescents. Thank you. It was a wonderful session. Thank you, Kavita, from my side.
Thank you, ma'am. Thank you for being here, ma'am. Thanks a lot.
Yeah,
Thank
Thank
you.
you.
Yeah. Thank
Uh,
you.
So,
Can I tell something?
yes,
I
yes,
think,
ma'am. I was
All
about to
the
call.
yes,
both
yes.
the
I think
speakers.
I should first congratulate Chhattisgarh Adolescent Health Academy for arranging these programs. And Chitra, you are taken great. I think you are taken on such a elaborately and with a clarity you are done a counseling. And but what MKC sir told, certain culturally appropriate. We get carried away because we read all the references from other country. Maybe I don't want to say developed, but still culturally appropriate way. But everything is very important for us. We should not deny that we have to do this counseling because many times we are not comfortable to do because we don't want to talk sexuality. Just now Himabindu madam told that talking about sexuality, this relationship counseling is a little difficult, but at least by which we can develop the healthy relationship skills, our thing, and promote the self-awareness, building resilience. We can encourage the healthy boundaries, at least that we can do. And this definitely will educate them about the consent and safety if you do appropriately in the clinic. And as already our teacher MKC sir made us in a simple language, what is CBT, what is DBT, what is REBT. So where we have to draw our limit, sir. Vinayak sir, I think he has made it so simple for us pediatricians or adolescent specialists that we should not cross our limit everywhere. So we should not get carried away. Certain things have to be done in a different way to refer to the psychiatrist. Without that, we may not be able to do justice to the patient. Thank you very much. I think next again we will have Dr. Chitra, you did really well. And Dr. Vinayak, you have clarified many doubts because that was little enigma for me at least to know about DBT, because we can't do for self-harm, suicidal thoughts, or maybe emotional dysregulation, because we are scared about the medical legal problems. The moment there are suicidal, self-harm, we tend to refer to psychiatrists. Should we interfere there? Doing DBT is always a problem for us to know about that. But I think now the doubts are cleared. Thank you very much.
Thank you, ma'am. Thanks a
Forward
lot.
for some more interesting sessions. Thank you.
Thank you. Thank you, ma'am. Dr. Kiran Makhija is also here. May we have some first from you, sir? Dr. Kiran Makhija, sir? Makhija, sir, are you here? Dr. Madhushri Deshpande, ma'am?
Thank you everyone. And very well taken by Chitra madam. A very difficult topic to talk with adolescent. At least I feel so. And it is so nicely taken with practical insights. Everything is given in the book, but how to talk and what to talk and where to talk and what not to talk. She has said it so nicely. Thank you, Chitra madam. And Dr. Vinayak has cleared what is really a DBT and how to go and what are the 4 aspects. Thank you, everyone, for enriching sessions.
Thank you, ma'am. Thank you. Dr. Amar Singh, sir, is there? Amar Singh Thakur, sir? Thakur, sir? Dr. AP Sawant, sir, is here?
Yes, Kavita.
Ji, sir, please.
Sessions are going very well. So first, I should congratulate Dr. Kavita as well as Dr. Preeti ma'am, that you have organized such a nice lectures and nice sessions.
Thank you,
Doctor, both the speakers are very good. Dr. Chitra, excellent. You solved so many problems of day-to-day practice which we are coming to all the times, and how to counsel these children is.
Thank you, sir.
You have given so many answers to all of us, and Dr. Vinayak is extraordinary for this subject, and he has very well cleared the difference between the CBT, REBT, and DBT. This session is very good, and especially I am thankful to Dr. Geeta madam, that madam in your presidentship you are organizing, doing so good work of Adolescent Academy. I congratulate you, and definitely will achieve a good goal for our adolescent can do better this year. Thank you very much.
So thank you, everyone. Thanks a lot.
Kavita, can I just make one point?
Yes, ma'am. Yes, ma'am.
Yeah. So though I agree with Vinayak that DBT needs a lot of training, but I would also say as an adolescent health specialist, take the certain tips, practical tips. You need not do the entire DBT. How to do emotional regulation? What is interpersonal skills? Definitely distress tolerance, doing mindfulness in clinical practice. I think we should take this as a way of coping up with stress, even. I would say that it's a part of our life skills also, which we use. So we may not do too intense of it, but so many good tips he has given us. I think these are very much adaptable and we can adapt it in our day-to-day practice also. Thank you, Vinayak, for a great presentation again. And of course, Chitra, you were awesome.
Thank you, ma'am. Thanks a lot. So with this, may I conclude the things? I, Dr. Kavita Menghani, Chairperson CGAHA, would like to thank each and everyone present here. And we are delighted to share that today we successfully completed our 5th session of series with more than 100 attendance every time. And this success, the success of this series is over to you, all the audience, your interest and your participation. So thanks a lot to each and everyone once again. And romantic relationships and management of emotions has become really challenging day by day. And I strongly feel that mandatory sessions should be included as part of the curriculum in all the schools, colleges, as well as the workplace. And I feel that this should be done by trained personnel like doctors or the trained personnel with this thing. So with this, I would like to pay my gratitude to our guests of honor, Dr. A.T. Tapkis sir, Dr. Sneha ma'am, and I extend my gratitude to our eminent speakers, Dr. Chitra Dinkar sir ma'am, and Dr. Vinayak sir for your enlightening talk. It was really very helpful for all of us for our day-to-day practice. And thanks a lot to both the chairpersons, Dr. Raghavendra sir and Dr. Akash Lalwani for smooth conduction of the entire program. I personally thanks all the senior persons present here in the session, Dr. Geeta Patil ma'am, Dr. Shalini ma'am, Dr. Amar Singh Thakur sir, Kiran Makhija sir, Dr. Umesh Khurana sir, Dr. Ima Bindu ma'am, Dr. Newton sir. Each and every, the list is long. So I'm really thankful. Dr. Neela Mohan ma'am, Dr. Sushma Desai ma'am was there. So I'm thankful to each and everyone who joined this session. And with this, I would like to conclude with my gratitude to everyone present here, all the office bearers of Central IAP, Central AHA and CGHA, and all the audience. Special thanks to all the audience. And very special thanks to Dr. MKC Nayas and Dr. Preeti Galgali ma'am for throughout the support. And last but not least, thanks to my technical team, Mayor, who arranged the Zoom meeting, Zoom platform at the 11th. I'm really thankful to you. So thank you everyone for this wonderful session and enjoy your Sunday. Thank
Kavita,
you.
last Kavita, I want to ask. My preteen granddaughter is here with me. She's listening to all.
So a special thanks to you for
USA.
joining us.
Yeah, she is there. She's Swara.
Very useful topic.
I hope she had got good impression of our session, ma'am.
Yeah, she's here and she wants to see what you are doing.
Okay, thank you.
She
Thank
listened something.
Neela ma'am, I hope your hair are done also. You can say something, ma'am.
No, it was really useful. And actually, I feel that this is a branch. It's not only for people who are counseling. That's what I just want to say. If there is one field which every specialist needs, is adolescent and counseling. This cannot be, because it is half the time we have to identify, pick, and then refer.
Yes,
So
ma'am.
it is not just training the counselors and the psychiatrists. At least we identify, because most of the time my psychologist always says that how beautiful you have an eye to pick up. So it's very important that this message goes to all specialty. I feel this is something which is extremely important. Just like we talk about nutrition, the second most important subject close to me is adolescent, and the way you identify the issues and talk about it. There's always so much to learn. I've never missed except 1 out of the 5.
Thank you, ma'am.
But there's
Thanks a lot.
too good.
Actually, this was the agenda behind this entire program. We pediatricians need to be sensitized. So the entire agenda behind this series was that only. Because we are the first person to come across with the patient. And then only we judge and then decide and then forward the patient to the further specialist. So thank you, everyone.
Thank you, everyone.
Thank you, everyone.
Bye-bye.
Thanks a lot.
Thank you. Bye-bye.
Special thanks to this kiddo.
Yeah.
Thank you. Okay,
Thank you.
have a good
Bye-bye.
Sunday. And happy Raksha Bandhan to everyone.
Thank you. Same to
Thank you. Same to you.
Same to you.
Bye.
Bye, bye, bye.
Bye. The light, okay.